Hello viewers, welcome to Asha Neuromodulation Clinic, Gachibowli. I'm Dr. Aswin and we were talking about the what and how of TMS. And in today's session, I've brought quite interesting material to you. We are going to talk about the role of TMS in psychiatry. How far are we justified in giving TMS as an adjuvant treatment in psychiatry? For this, we have to go a little to the basics of understanding human behavior. Viewers, let me tell you, psychology or psychiatry are ultimately dealing with human behavior. An altered behavior is what they are interested in because they want to bring the altered behavior back to the normative or the accepted behavior. Alright, how do we understand the neurobiological basis of behavior? Because we have learned that through RTMS, we are going to stimulate certain parts of the brain and hence bring a change in the human behavior. You remember in the first or the second sessions, we were discussing about scientists using the PET scan. They have discovered that some parts of the brain like left-sided dorsolateral prefrontal cortex is underactive or hypoactive. Do you remember that? Right. So definitely there is a brain area which is non-functional, or maybe I can say it is not so functional, alright, in certain given psychological condition or a psychiatric condition, which is producing an altered behavior. And hence I want to target that area. To understand this, let me give you a small example. Say, take the example of an apple and a knife. I give you an apple and a knife and I put them in front of you on a table. And then I'll see what all behaviors can you produce. Say you're so hungry, what will you do? You will obviously grab the apple and eat it. Of course, all hungry people do eat it, I agree. But don't you think there are quite differences in the behavior? One person might grab the apple, peel the skin off, and then cut it nicely, symmetrically, and then eat piece by piece. Or somebody else like me who would like to just grab the apple and bite it directly. Few people wanna clean or wash the apple and they're not convinced at doing once or twice, but they do it again and again. Don't you think the same inputs, the apple and the knife, which are given to the brain now, the information going into the brain is generating different types of behaviors? Yes. Now consider a patient who is in depression, who doesn't have a lot of motivation to do activity or kind of interest, he has lost interest in his life, and then you offer him an apple and a knife, what he might do? He might as well reject eating an apple despite he being hungry. Okay, then where is the change happening? That brain area which is helping you to produce an output to a particular environment, the apple and a knife in this case, that area is non-functional. Or somehow somebody is pulling down its leg. Maybe the lack of drive or motivation is pulling that down so that the person is not able to execute a behavior. Getting it? Or say we were just talking an OCD patient. Obviously an OCD patient might wash the apple some 10 times, 12 times. There is a magical number. And maybe he is exhausted in washing the apple, but never he could fulfill eating the apple. Or the other way around, he might cut the apple in so symmetrical, maybe he measures and then cuts, I don't know, but that is possible. So what's happening here? From the same given inputs, an apple and a knife, a variety of behaviors are coming up. And in that, few are signature behaviors I call, because every one of us have got our own style of doing things, or they may be pathological behaviors like in OCD or in depression. So what we understand is that when sensory information is received by the brain, there are certain parts of the brain which process this information and generate a behavior. When these areas are going wrong, the behavior shown by the patient obviously is wrong. What a psychiatrist does is, by giving some medicine, which is the reason for the imbalance in the functioning in that particular area, they achieve or they target to balance the chemical levels in that areas and hence bring the behavior back to normal. And few others like psychologists, what do they want to do is that they want to give some therapies or counseling or insight into the patient, letting them to know that no, this is the wrong behavior you have chosen to, maybe you could switch over to another normal or an accepted behavior. Alright. But what RTMS does is, RTMS hits the target. When the brain area which is responsible for the altered behavior, you are hitting straight away to the target, and then you are modifying its activity. Like we have seen the effects shown by the RTMS, the classical and the non-classical ones, will eventually produce an automatic change in the behavior. We at our Asha clinics have seen depression patients walking into the clinic with a sad mood, and then after 5 days of treatment, on day 6, I underline day 6, they are back to some good amount of accepted behavior. I mean, the scores which are recorded using standardized tools, you call, for example, Hamilton Depression Rating Scale with 21 items for depression, they have shown a greater than 60% change in the HAM-D. We could actually feel the happiness, and we could share the happiness from the patients and their relatives. So is the case with OCD. In OCD, we will target certain other brain parts which are directly in communication with some, you call them as subcortical. They are below or somewhere inside the brain, called basal ganglia. So these areas are somewhat where in the midline, okay, the dorsomedial, prefrontal and anterior cingulate, orbitofrontal, there are many. So when we were targeting in OCD patients these particular areas, again we saw a change on day 10. So day 1, the patient steps into the clinic with severe distress, with a kind of anxiety and kind of guilt, and they could not stop their compulsive behavior and so on. And now we hit the target, that is the areas which I just mentioned, and then on day 10 they are able to control or manage themselves, and the intensity or the severity of the disease as measured on a scale like Y-box. There is a scale called Ale-Brown obsessive compulsive severity scale. So such good differences when you observe is really quite interesting for us to observe in our patients. And what is the reason for everything? Again, the neurobiological basis for the behavior, and hence I say application of TMS in psychiatry is yes, 100% justified. Thanks for watching. We are going to meet again in the next video, wherein I am going to share quite more informative content about TMS. And I'm signing out. Before that, I would like to say, keep learning, stay young. Thanks.